delighted to welcome Dr. Joshua Belfer, who's a peds-emerg physician at CHOP. He is the founder of PEM, which is an educational blog, and his interests lie in medical education, digital scholarship, and knowledge translation. He's going to talk to us today about clinical dilemmas in the management of febrile infants.
All right, thank you, April. Hello, everyone. Just share my PowerPoint here. Thanks for having me. I see a few familiar names on here. So like April said, I'm going to be talking about the clinical dilemmas in the management of febrile infants. I'll first tell you how I came up with this talk. We're going to talk for way of context. We'll talk a little bit about the sort of stereotypical febrile infant 0 to talk stemmed from when a lot of you probably know that CHOP is known for a lot of things, but one is the clinical pathways that are openly accessible and readily available. It helped a lot as a new attending. The residents would often follow the pathways and oftentimes would come to me with their assessment and plan. We're going to do the moderate asthma pathway. We're going to do the UTI pathway. And as I spent, a few weeks, a few more months at CHOP, then every so often there'd be a few standout cases where the residents who were great would come to me, they would present their cases to me, give me their assessment, and then they'd kind of hesitate when they came up with their plan. They wouldn't really commit to a plan. And after several of these, I went up to them, I said, every other patient you presented to me, you're coming up with a concrete plan, a great plan. So what's different about this patient? And so as I asked them, they responded pretty similarly each time. Okay, well, I had this case 2 weeks ago, and this attending, did this thing for this patient. But then I had the same sort of case last week, and my attending did something completely different. So I don't really know what I should be doing for this patient. And so this is how this lecture was born. It's a series of 5 cases that kind of live in the gray area, sort of off of the pathways. We're going to review some of the evidence for each of these cases to hopefully, familiarize or refamiliarize many with these scenarios to help inform how you're going to take care of these kids. A few caveats before we go gray area. This is necessarily what the evidence says. First is sure, but for a lot of them, hopefully we are equipping everyone with more evidence and more recent evidence about how they can inform their own practice, because there is going to be some practice variation. Of course, with a lot of these, we're talking about bacterial infection in young children, so we need to consider the potential biases. A lot of these studies only include children who had, say, blood cultures done, blood cultures and spinal taps, urine cultures done. And so, with a lot of these studies, retrospectively, it's tough to pin down exactly what the clinician was thinking, but there is some potential bias in that we're only including some of these children that had these testing done. At some point, someone decided, yes, this child needs these testing. And then the third, of course, we always look at what are the overall differences between the populations that we're studying. Can we risk assess these patients to do more testing, to do less testing, to do antibiotics? But when it comes to these children, as we all know, with the febrile infant, sort of how much risk is too much? What are you willing to put up with in terms of your risk? And so when we talk about these studies, we'll talk about, yes, there could be a difference between the populations we're looking at, but what's the overall risk of bacterial infection? We will touch on in a second some of the sort of stereotypical febrile infants, but infants, I know there's something about infants that, maybe, of course, they could present with subtle signs. One sign, say vomiting, not feeding well, can be the initial sign in a patient that will become septic. Of course, we think about fevers. We'll touch on hypothermia. The afebrile child, what is their risk of being seriously ill? We won't touch on this today, but infant botulism, certainly these kids are septic appearing and afebrile, which may be reassuring for some when you see the vital signs, but certainly not necessarily a predictive factor of well appearance. The duration of illness, obviously these kids have low reserves sometimes and can get sick very quickly. Vaccines we won't talk about a whole lot, but there's a number of studies in terms of how soon after they get their 2-month vaccines can we reduce the risk and worry less about bacterial infection. Physiologic differences, congenital issues. I'm not going to touch on that as much today, but another septic appearing infant, congenital adrenal hyperplasia is a classic case that we see the septic appearing infant due to a congenital issue. Ultimately, why are we so worried about these infants when it comes to bacterial infections? Of course, the nomenclature has changed over the years. Serious bacterial infections, or SBI, which includes UTI, bacteremia, and bacterial meningitis, seen up to 12%, sometimes higher, of all febrile infants less than 3 months of age. Of course, a lot of the studies have now focused more on invasive bacterial infection, or IBI, acknowledging that most of the bacterial infections in this age is going to be UTI, lower morbidity, lower mortality than when we're talking about bacteremia and bacterial meningitis. And so we do know 1 to 2% of these children less than 3 months of age with fevers will have IBIs. Delayed diagnosis, of course, is something that we're very worried about, increased morbidity and mortality. And ultimately, this bottom right box is really the bane of our existence in the pediatric ER. It can be very difficult to differentiate benign viral infections from even bacteremia and sometimes bacterial meningitis based on a single thing alone. And of course, we'll talk about some of the studies, and I'm sure a lot of people are familiar with some of the studies of what tools and what labs are used to risk assess. Older algorithms, the Rochester criteria, the Boston, the Philadelphia, of course, look a lot different than what we use today. And why is that so? Over the past several decades, we've seen changing bacteriology, of course, better prenatal group B strep screening, strep pneumo vaccination, improvement in food safety, a real shifting from gram-positive to gram-negative, and namely E. coli predominance when we're talking about bacterial infection in these young children. More readily available testing in terms of C-reactive protein, procalcitonin, rapid viral pathogen identification has started to assist us in terms of risk assessing these children. And then, of course, the acknowledgement, the cost of unnecessary care, not just financially, but the burden, the emotional burden on families with a newborn child to have to come into the hospital, get all these testing done. Lumbar puncture, of course, is something that's been well studied, provides a lot of emotional distress for families. And if we don't have to do it, if we're able to risk assess these kids in other ways and potentially send them home or potentially not do a spinal tap, then families can be a lot happier potentially. This all culminated in August 2021. The American Academy of Pediatrics came out with their clinical practice guideline. I'll show you what the CHOP febrile infant pathway is here. It's not as comprehensive as the AAP guideline, but you could see here the AAP guideline really has carved out this new age group 22 to 28 days old, where we could risk assess these children with blood work and urine and potentially not do spinal taps on all these children. Older children, we were already doing that. And then traditionally, historically, first 3 weeks of life, you do everything: blood, urine, spinal tap, and mit for antibiotics. That was until a few months ago, a study came out that I'm sure many are familiar with, and I think I saw Brett join this call. Brett Burstein and Nate Cooperman came out with this study, showing that we could potentially risk assess the first 3 weeks of life with blood and urine, and potentially not have to do spinal taps and not miss bacterial meningitis. There will be a plug at the end, but this is my first plug for my blog. Like April said, Hypothermia, we started about a year ago. We've had dozens of authors contribute, pediatric emergency clinicians, pediatricians, emergency clinicians. You could use this QR code to get directly to the interview I did with Brett and Nate talking about their recent study. There'll be another QR code at the end. I'd encourage everyone to check it out. And certainly, if you are interested in contributing, writing articles, please send me an email. We are always looking for authors. This will be, aside from the febrile infant pathway I just told you, this will be really the only pathway I'm going to show you for the rest of the time. These are the 5 cases that we'll walk through. There's some poll questions scattered throughout. I'd love if everyone would participate in the poll questions so we could get a sense of how the group would treat these children, and we'll go through the evidence. The framing of these cases will be the case, poll questions for some of them. We'll go through some of the evidence, and I'll sort of talk through what I tend to do. But again, I would love to hear, at the end or as we go through, you can put in the chat, how people would manage these cases differently, because there is a lot of variation. First case, named it, yes, they're 64 days old. Oftentimes when we have an infant come into the ER, say 2 months they come up on the board as, think the first thing in the chart, even before vital signs are done, is someone types in the comments, this child is 58 days old. This child is 61 days old. I think many are looking for a reason not to do blood work and urine right off the bat. Okay, they're 64 days old. Maybe we won't have to do much of a workup for them. So this is our first case, a 64-day-old, well-appearing, full-term female coming to the ED with 1 day of fever. Was warm at home, no other symptoms. Feeding well, no congestion. On exam, temperature is 100.8 Fahrenheit. You see a smiling infant, feeding well, no respiratory symptoms. And our first poll question, Regina, if you want to launch it, would be what workup would people do for this child? We have reassurance and close pediatrician follow-up, urine studies, no labs, urine and labs right off the bat. Labs, consider LP, and admit on antibiotics. All right, we have about half the group answer so far. We'll give it another 10 seconds or so. All right, we'll end the poll. We'll share the results here. You could see a lot of variation in terms of just our group here. About a quarter of people would say reassurance and close pediatrician follow-up. This patient's well appearing. Send them home, see the pediatrician in a day or two, as long as they're still well appearing. Almost half the group said urine studies, no labs, and then about a third said urine and labs. So good. So there's a lot of variation, which is when I've done this talk in the past, it tends to be around the same variation. And when we look at the research, of course, what we see in this group has been seen in the literature as well. Study done looking at what ED clinicians do for febrile infants. In the 29 to 56-day-old group, about half of them got blood, urine, and CSF. Of course, probably going based on a pathway or based on the clinical practice guidelines. About a quarter did blood and urine, 3% did urine only, and then there was a mix of several other different types of tests or even no testing at all. When you extrapolate that out to the next age group, 57 to 89 days old, far fewer did blood, urine, and CSF. About 42% did blood and urine, 12% urine only. So again, a lot of variation. People do different things. I think owing to the fact that there's not a clear clinical practice guideline, these children technically fall out of the AAP febrile infant guidelines, which only go up to 60 days. So there's a little bit of user variation. So then the big question is, what's the rate of bacterial infection in these children compared to the younger children? A good study done, about 3,300 infants less than 3 months of age, looking at serious bacterial infection, meningitis, bacteremia, and UTI, and you could see in these white boxes split up by age group. Less than a month of age, 21.5% had an SBI. That decreased in the first to second month, 29 to 60 days of age, and then actually increased over 61 days to 90 days. And so, of course, you initially see this. Is this worrisome? Are we missing children with bacterial infection in 2 to 3 months of age that we should be doing additional testing for? And of course, as you could guess, the vast majority of these children, the numbers that are increasing at that 2 to 3 months of age are the UTIs, the non-bacteremic UTIs. When we look at the IBIs, the meningitis and bacteremia in these age groups, this is the trend that the studies before this have suggested. This is the reason why we worry less potentially about these children 2 to 3 months of age. 5% chance of them having an IBI in the first month of life goes down to 2.3% in 29 to 60 days old, and then 61 to 90 days old, 1.1%. You can see the breakdown of the 14 cases of IBIs in the 2 to 3 months of age group. There were 2 kids with sepsis, 6 with occult bacteremia, 6 with bacteremia with a source, mainly UTIs, and 0 cases of meningitis. So, right, a lot of people, no one said in our initial poll that they would do an LP right off the bat or even necessarily consider an LP in this well-appearing child. But, as you could see, if you're going to do testing, urine seems to be the most common thing. So that would be, definitely seems like the group would want to do that. But certainly there are some cases of bacteremia that we see in these well-appearing infants with fevers. A more
Hi,
recent
Josh.
study done.
Someone in the
Yeah.
audience was just asking what year was that study done?
Say that one more time, April. Sorry.
I think Mike Falk was asking what year was that study done?
Let me take a look. That was done 2019. And then the more recent study here, that was published over the last year, looking at a prediction rule. Looking at kids that are low risk for invasive bacterial infections in the 61 to 90 days of age group. Using the PCARN registry, looking at 5,000 children, 61 to 90 days old, they found that 2% had bacteremia or bacterial meningitis, and they created two rules. Acknowledging that not all institutions have readily available procalcitonin, CRP, even if you're thinking if you're going to potentially manage these children from a pediatrician outpatient's office and not necessarily have access to blood testing readily available, this is a rule that you could use without using blood testing. So infants with a negative urine and a maximum temperature less than or equal to 38.9 Celsius were found to be low risk for IBI with a sensitivity of 86%. The second rule that they came up with was incorporating the procalcitonin in CRP. You could see the thresholds listed below. And infants that did not meet the threshold for the procalcitonin and ANC, in these febrile infants 61 to 90 days of age, were at low risk for an IBI with a sensitivity of 100%. So I think with this recent study, we could show that if anything, if you're worried about the children and you want to risk assess, blood and urine seems to be the way to go about it. And if you don't hit these blood thresholds, the risk of IBI is quite low. When we think about the older children, okay, we've talked about 2 to 3 months of age. Now let's go up to 2 to 6 months of age. These were a couple studies done by Becca Green, one of my colleagues at CHOP, looking at the prevalence and management of IBIs in febrile infants 2 to 6 months of age. 21,000 febrile infants they looked at, 0.5% with an IBI. You could see the breakdown. Very few cases of bacterial meningitis. Most common pathogen, probably not surprisingly, E. coli and group B strep. Of course, what we'd like to see in this age group is that, okay, we could use our clinical gestalt to say, I can see a child, I can take a history, I see the vital signs, I do my exam, and I can tell you whether I'm concerned for an IBI. We know that potentially we can't do that in the first few months of life. This study, these two studies seem to suggest that, yeah, we probably can pick out those children between 2 and 6 months of age that are at higher risk of an IBI. History of medical complexity, the premature children, if obviously they have an ill appearance in the ED. When we talk about the 2 to 6 months of age, that first half, the younger children are at increased risk, and then peak temperature. Those of you familiar with the AAP clinical practice guidelines, temperature threshold is included in terms of a potential inflammatory marker that can be used if some of the blood testing is not available. And so this sort of played out in Becca's study as well. We could use these as predictors for the 2 to 6 months age group of concern for IBI. What I tend to do is probably similar to the group based on our poll. If it's at the very beginning of the illness, I think shared decision making is appropriate. If it's during the week, parents can follow up with the pediatrician the next day or two. The kid is very well appearing, 1 day of fever. I think, I tend to talk with them. If they really don't want to do any testing, then I think that's appropriate as long as they have proper follow up. If I'm going to do testing for this well-appearing infant, I think urine is the way that I tend to do it. If there's something that's different, if they're not feeding well, if they're a little bit fussy, if they just look a little bit not super well appearing, I think blood and urine. With the elevated inflammatory markers, I think even if they're elevated, with a well-appearing child, I think I'd be hesitant to do an LP right off the bat just based on the inflammatory markers. But certainly there'd be a discussion in terms of whether you admit on or off of antibiotics, or whether you have the discussion to do an LP and admit on antibiotics. For these older children, like we discussed, I think a younger child with higher fever, without a clear source, blood and urine. If they're ill appearing, of course, blood and urine. And then those children with complex medical history, with a premature birth history. If you really don't have an alternative source, urine is the first way to go, I think. And then, of course, low threshold for blood. Next case that we'll talk about, we're going to take that same infant that we talked about in the first case, 64 days old, well appearing, who has 1 day of fever but has cough and congestion. How many kids do we see even though the weather is 70 degrees outside? Temperature is 100.8, nasal congestion, a little bit of belly breathing, but clinically stable to go home. What workup would you do? Sergey and ask you to launch the second poll, and it's the same question as the first one, the same answer choices. For this child who has a fever but also has cough congestion, reassurance, urine in labs, or do you still say, okay, I'm going to do urine labs and think about LP and antibiotics? All right, we have about half of the group who's voted. We'll share the results here. not surprisingly, compared to our first poll, a lot more people would say reassurance and close pediatrician follow-up. Still a couple people who do urine studies, even though the child has respiratory symptoms, and then a couple who do urine and labs. So then the question is, of course, what's the risk of bacterial infection with viruses? And we'll talk about two studies done over the last sort of 7-8 years. First one's a small study done by Nicholson, looking at 104 infants less than 3 months of viral illness. About two-thirds of children were PCR positive for respiratory virus. 16% had an SBI for about a 9% rate of co-infection. When they initially looked at the results, about 13% had an SBI when they tested positive for a respiratory pathogen. 24% had an SBI when they tested negative. These numbers were not statistically significant. So you look at it, okay, maybe there's a trend towards those children who were tested positive being at less risk of an SBI. And so then they took it a step further and said, okay, not only can we identify, we could have viral testing, we could identify the exact virus that these children have. So can we risk assess based on the specific virus that children had? And they separated these children into mucosally restricted viruses, RSV, flu, coronavirus. Here at CHOP, those are the top viruses we tend to test for, during the peak winter respiratory season, are sort of quad, flu A and B, RSV, and COVID, versus the systemic viruses, those that tend to cause viremia more often, enterovirus, adenovirus. And so they asked the question, okay, if you have a certain virus, does it lower or increase your risk for bacterial infection? What they found is those with a systemic virus or with a negative virus test had a significantly more likely to have an SBI than those with mucosally restricted virus. So said the other way, if you have a mucosally restricted virus, RSV, influenza, coronavirus, you are at significantly decreased risk of having a serious bacterial infection. Much bigger study done through the PCAR network, 2,900 febrile infants less than 2 months of age. Any serious bacterial infection, you could see these numbers were significant. If you tested positive for a virus, you had about a 4% chance of having an SBI. Viral negative, 13% of children had an SBI. And these were significant for UTI and bacteremia alone as well. If you think back to the second slide I showed in terms of the caveat that, okay, we need to look at the differences in risk for these children, but then the overall risk as well. This is really the slide where it plays into. You look at this first line, SBIs less than or equal to 28 days old. Okay, if you're viral negative, you're about 4 times more likely to have a serious bacterial infection. But even if you're viral positive, you still in this series had a 4% chance of having 4% children had an SBI in this age group. So we look at why we do what we do when it comes to the first month of life, or at least what we traditionally had done. These children, even if they have clear viral symptoms, even if they test positive for a virus, still a 4% chance, still 4% of them are going to have an SBI. As you go down this table here, you can see the vast majority of these infections are UTIs, but it is still a non-negligible risk, even if they test positive for a virus. More recent study done over the last year, looking at PCAR data set when it comes to children 61 to 90 days of age. 3,700 febrile infants who had urine or blood testing and who had respiratory viral panel testing. Almost 50% of children had a positive viral test in this population, and you could see the differences in those children who had viral positive versus viral negative when it comes to the infections. So UTI, those if you tested positive, you had about 4.4% of them who had a UTI versus if you tested negative, 12.5%. This was statistically significant. Similarly, with bacteremia without meningitis, you could see a significant difference between them. 0 cases of bacterial meningitis in those kids that tested positive for a virus, and a couple in the negative group. When you look at what our first study showed in terms of the individual virus and whether that plays a part in it, when we look in the left panel here, bacteremia without meningitis, COVID was really the only individual virus that if you tested positive for, you would decrease risk compared to those children who tested negative for a virus. When it came to the UTI in this right panel here, each of these viruses listed below, COVID, RSV, influenza, did lower your risk of having a UTI versus those children who tested negative for a virus. So what I tend to do for these children, 2 to 3 months of age, who test either positive for RSV, flu, or COVID, or have a significant history in terms of sick contacts at home. They're in daycare, the whole family is sick, they have clear viral symptoms. If they're overall well appearing, likely I'm not going to do blood testing. Oftentimes, probably not going to do urine testing if they're at the beginning of their illness. If there's something off, if they look a little bit sicker than sort of the run-of-the-mill virus, I would think about doing blood and urine testing. Urine would probably be my first step, and then a decision about whether to do blood testing. Like we talked about, that first study reinforces why we do what we do for kids less than 2 months of age, even if we know that they have a virus, especially in the first month of life. I think this last point, as the research continues to progress, I think this probably will be a continued conversation. As kids get closer to 2 months of age and they have clear viral symptoms, we see that the risk of bacterial infection, namely bacteremia and bacterial meningitis, gets lower and lower. So does a 6-week-old always have to come into the ED to get blood and urine testing, as sort of our CHOP guidelines say, as the AP clinical practice guidelines say? Perhaps as they get closer to 2 months, and look, I think there's probably acknowledgement that some of these children who have good pediatrician follow-up and good communication with their pediatrician, or if they don't live close to a hospital, there are probably children who are managed like this already from the outpatient setting. I think these studies suggest that maybe there's even more of an opportunity as we get more and more studies to suggest that these children, maybe we don't even have to see them in the emergency department. Maybe they can be managed in the outpatient setting. And yeah, I see the point here about, you know, depends on point of care testing for viruses, not done in all centers. Absolutely. And I think some of this would suggest if you have a well-appearing child, even with clear viral symptoms, even if you don't have testing, perhaps you can manage them the same as you would these children who tested positive for RSV. Next case, what about ear infections in this age group? Not an issue that we think about too often, but one good study has been done, and that I want to talk about here today. So 51-day-old, well-appearing child coming in for, parents say, just something's off. She's, maybe acting a little bit differently. Either maybe your resident goes in, we ask our whole review of systems. Are they pulling at their ear? Oh, yeah, actually, now that you mention it, yeah, they were pulling at their ear. Now, those of us who see all these children, how many of these kids, okay, they discover their ears eventually and they're all pulling at them and they're playing with them. So, take it as you will. But you look at this child's, they're afebrile. You look at this child's ear, and okay, you make the case. Okay, the tympanic membrane is red. It's a little bit bulging. So what do? And Regina, I'll ask you to launch the third poll question. The big question is, if this child was 3 months, 4 months, 5 months, okay, either wait and watch, maybe send a prescription that they could fill in a day or two if symptoms persist, treat with antibiotics. But the 51-day-old, right, if they spike a fever, you'd want to do blood testing, you'd want to do urine testing. And so are you going to throw antibiotics at this child? Are you going to do antibiotics, but also do labs, send a blood culture? So then if the blood culture it comes back, at least it was done pre-antibiotics. Or are you going to initiate, okay, this kid potentially has a bacterial infection in one place. Do I need to do labs, LP, and antibiotics? All right, wait for a few more responses. All right, we have about half the group. We'll share the results here. A lot of variation. Interesting. 7 people said they would just observe. Probably people are making the case, okay, how often are we seeing these young children with true ear infections? They were crying, maybe the TM is red because of that. 10 people would say oral antibiotics, treat this kid the same way that you would if they were 3 months, 4 months with an ear infection. 7 people would say, okay, we're going to do antibiotics, but let's do the lab work as well, and then 1 person would do it all. So what does the data say? This is done by Sun McLaren up at Columbia, where I did fellowship. Looked at invasive bacterial infection in afebrile infants diagnosed with an acute otitis media. It's important to note that this was one clinician diagnosing. There was not a second clinician that would look in the children's ear to confirm that that they agree that there was tympanic membrane bulging or erythema. 1,600 infants. You could see the breakdown of how many got blood cultures, CSF cultures. Almost about a half of them had 30-day follow-up, so I think a lot of them were captured in terms of whether they returned to care. 0 cases of bacteremia, 0 cases of bacterial meningitis, and 2 adverse events. If you look at the table here, adverse events, One child was sent home on amoxicillin. 3 weeks later, came in with cervical lymphadenitis and a perforated otitis media. The second one, culture negative sepsis, thought to be secondary to severe milk protein allergy. So overall, when we're thinking about IBIs in this age group, seems to be, zero. Uh, couple When this study came out, there were a few commentaries that were written about it in the same journal. Of course, like I mentioned, there's the inability to verify the diagnosis. We know kids can get tympanic membrane erythema from viral infections, from crying, so there probably was an overestimation of good outcomes. Very few of these children were less than a month of age. What to do with these infants? I would imagine a number of you are sitting back and probably saying, okay, like how often do we really diagnose otitis media in these kids 1 month of age? A febrile child, I'm sure there's a couple of us say, okay, how often are we even looking at these children's ears when they're well appearing, they're afebrile, they're feeding well, they look good otherwise? I think what I would do in the 1 to 3 months of age, afebrile, well appearing, I'd probably, think about watch and wait if they have good pediatrician follow-up, if they're still feeding well, and if they're not irritable. I would either re-examine the ear later in the ED stay, maybe close follow-up. Of course, if they spike a fever, that changes things, but you probably have a little bit of time to not throw antibiotics right away at these children. The big thing, right? You start antibiotics, the child spikes a fever, and the next day they're in the ER seeing your colleague, and your colleague looks at the chart and say, "Oh man, what am I supposed to do? Because my colleague here the day before sent this child home with antibiotics. We don't have a blood culture. What are we supposed to do?" Now, more and more, I think when talking again about Brett and Nate's study, if an infant spikes fever that first month of life, even if they were pre-treated with antibiotics, and maybe you could risk assess these children with lab work. I think again, I'd err on the side of probably not treating these children, thinking that there are probably other reasons why they have erythema in the tympanic membrane, and then good follow-up, watch and wait. Next case is called just swaddle and recheck a temp. 38-day-old, and I would say probably aside from the viral symptom case that we talked about, case two, I'd say this is probably the case that we see the most, and I'm going to guess there's going to be a good amount of variation with this as well. 38-day-old, well-appearing, full-term female coming to the ED for fussiness, some poor feeding that the parents are reporting. Do a temperature and triage. It's 36.1 Celsius, which is 97 degrees Fahrenheit. Looks well on exam. Aside from the temperature, you would say this child looks fine. They feed in the ED. They're doing great. Otherwise, I would send them home. But do I care about this temperature? Surgeon, I'll ask you to launch our last poll question. What temperature does everyone consider as hypothermia? I came up with some thresholds here, although I would encourage people to pick the closest one to what your threshold would be. 36.5 Celsius, 36.2, 36, 35.7. Probably could have included another option here. I don't have a threshold, which I think would get a lot of activity here too. All right, we have about half the group here. Share the results. The most common threshold people chose is less than or equal to 36 degrees. So 7 people, about a quarter of the group that responded, 36.5, and then you can see there's some variation in here as well. So okay, everyone's going to have their own threshold for hypothermia. Then the natural question is, okay, I say that this child is hypothermic, it's 30 some odd days old, can we treat them the same as the febrile infant? Is this an incidental finding of hypothermia or a sign of impending doom? Up to 8% of infants with hypothermia coming to the ED have a serious bacterial infection, and hypothermia may be a sign of poor outcome when children do have bacterial infections. Study done a few years ago, well-appearing neonates with incidentally noted hypothermia at a routine outpatient visit are at low risk for serious infection. I'll give you a little story here. I have a 6-month-old baby. We just went to the doctor for the 6-month shots in the exam. I had just seen several cases of a hypothermic infant or a child who was brought in because there was concern for hypothermia. Okay, I figured I'd ask our pediatrician. We really like him. He's very experienced. What do you do on the outpatient side for these children? Of course, they get the phone calls for the after hours phone calls. They see children in the office. And he said it's pretty interesting. they tend to see the newborns or the first month or 6 weeks of life on Saturday mornings. Why? Because it's a time that families can come in. They sort of dedicate the first few hours of the morning for only the newborns in the first few weeks to come in to lower infection risk. Makes sense. Now, what's the problem with this? Night, no one's in the office. Everyone comes in. It's colder in the office because no one's been there all night. Additionally, the office is colder. What do you use to do the rectal temps? You use lubrication. The lubrication packets sitting in the drawers in each of the rooms are also cold. And so they started to see, okay, they're getting, when they would do the temperatures, routine temperatures on these well-appearing kids, they had some hypothermia. And so they did some QI work there. They decided to change the practice. And of course, they still see these children Saturday morning, but they say, okay, as soon as the nurses come in, you take the lubrication packets, take them out, put them in their pockets, put them in, sort of warm them up however you can, so that when these newborns come in, we're not having environmental factors contribute. So, some would say, okay, of course, if you're incidentally found to be hypothermic in an outpatient setting, maybe there is some environmental things. Versus, if you do come into the ED for a number of reasons, whether it's because the parents think that the child's acting differently, whether it's that the outpatient pediatrician triages it and tries to warm the child up with environmental reasons and they don't warm up, maybe these children that do come into our ED are at increased risk for bacterial infection. We know that hypothermic infants are on average younger and more likely to have temperature instability, and so these first few weeks of life, if they're hypothermic but well appearing, is it's just a lack of maturity in the thermoregulation versus we know hypothermia and sepsis can be due to altered immune response. With the same question that we asked before, can we use the same inflammatory biomarkers? Not surprisingly, survey done a couple years ago, 1,200 plus ED clinicians. Similar to our results here, the most common cutoff to define hypothermia was 36 degrees Celsius. 13% did not have a specific threshold. I think, if we pinned everyone's answers down, I think there'd be some variation in terms of, okay, it's context specific. I need to see the child in front of me, and maybe the kid that's 36.1 in certain contexts I would say is hypothermia versus other times I would say it's not. The tables here on the right, the charts, you could see a lot of information and the colors are pretty similar, but you could see for each of the age group, the first two bars on the left are blood and urine respectively. You could see here as the child gets older, people still do blood, but it sort of drops off between 1 month and 2 months of age. Still a decent amount of urine testing, but certainly CSF testing goes way down. A lot of good studies when it comes to the hypothermic infant and their risk of bacterial infection. So we'll go through just sort of the highlights of some of them, but I included some of the references, and I'm happy to share the full references for those who want to go back to the articles. The top two boxes are the questions posed by each of the studies, and the two boxes at the bottom answer them, the conclusions from the study. Top left, is there a hypothermia threshold to predict serious bacterial infection? Looking at almost 3,400 hypothermic infants to try to statistically derive a temperature threshold. Similar to what we use in terms of our clinical gestalt, they were not able to come up with a hypothermia temperature threshold to reliably identify SBI or IBI. Probably owing to the fact, like we just said, a lot of us would say it's context specific. And the second question, can the febrile infant rules be applied to the hypothermic infant? Study done in Hospital Pediatrics journal a few years ago, looking at several of the different clinical practice tools and whether, okay, they use less than or equal to 36 degrees Celsius. Can we apply the same rules we would for the febrile infants to these infants? And they did show that for the Philadelphia and the Boston, and probably most importantly, the AAP clinical practice guideline decision-making tools did not misclassify any SBIs or IBIs as low risk. Of course, it has low specificity, so you're going to be doing a lot more testing in these children, but you're not going to necessarily miss any of these children. A few other studies that were done. Can we use other clinical signs in addition to hypothermia to risk assess these children when it comes to bacterial infection? Two studies you could see here on the top left. The prevalence of serious infection was 2.6% in those that were hypothermic versus 15% in the febrile infant. If you're hypothermic, you're at less risk probably than those kids who are truly febrile. But hypothermic infants tended to have other things that you could use to risk assess. either medical history, history of prematurity, a history of poor feeding. Of course, lethargy and ill appearance is going to make you think about bacterial infection. And then in the bottom right, those children aged greater than 21 days old, I think owing to the fact that the first week, maybe even week and a half of life, there is probably some, building maturity of the thermoregulatory systems. And so maybe these children who, okay, maybe they stayed in the nursery for an extra day, maybe they were in the NICU for a day just to keep their temperature up. They go home, their temperature drops again. Maybe there's a little bit more wiggle room because these children probably are at a little bit less risk versus 3, 4, 5 weeks of life, truly hypothermic. I think you treat these children the same way you would as a febrile infant. What I tend to do, like I mentioned, first week of life, we have the benefit of close working collaboration with our NICU colleagues at several of our hospitals. So oftentimes I will speak with the NICU providers and say, okay, this child is 4 days old, 5 days old, well appearing, maybe has a history of needing some temperature stability in the nursery, and I think this child needs to be admitted, but maybe the temperature normalizes 36.1, 36. If I decide not to do blood, urine, and CSF, sort of have a shared conversation with our NICU colleagues to say this child needs to come to you. Let's jointly kind of decide, how we want to risk assess these children. Older neonates, of course, less lenient, especially if they have associated symptoms. I think the first thing is to correct the environmental factors. How often do we see the children, okay, they were cold at the pediatrician or cold at home, they bundle up, maybe they're still a little bit cold, the parents brings them into the ER, we got our blankets, we get them inside, we check temperatures, we trend the temperatures, and they normalize out on their own. These children I tend to watch probably several hours in the ED, as long as they maintain their temperature without a warmer, without any other things besides, say, blankets and swaddling with the family. Oftentimes, I do not do a workup on these children. Less than 3 weeks of age, of course, has been trickiest because traditionally we weren't risk assessing these children with blood or urine. Now, with the new study from Brett and Nate, maybe we can start doing that. And of course, at the end of the day, when you're concerned, you do it all. If you're concerned that this child is truly hypothermic, even if they normalize their temperature, but something still feels off, blood, urine, think about doing a spinal tap. Because hypothermia, of course, can be the initial presentation of a bacterial infection. We'll go to our last case now, the premature infant. 63-day-old, well-appearing female, born at 29 weeks, coming in for fussiness and a fever. Looks okay on exam. No respiratory symptoms, has a fever to 101.1. So then the question is, do you treat them the same as you would a 63-day-old? And maybe like we did in our first or second case, okay, maybe you do some urine testing, but not much else. Or do you treat them as their corrected age? Say, okay, their corrected age is 38 weeks. I need to treat this child like I would, say, in the first 6 weeks of life. We'll go through 3 studies quickly that talk about bacterial infection risk in the preterm infant in the first 3 months of age, at least for this study, showing that the incident rate of any IBI, bacteremia, bacterial meningitis, was higher in the preterm children than it was in the full term. You could see that the highest incident rate of IBI in the chronologic age 7 to 28 days and or 37 to 39 weeks post-menstrual age. As the children get older, and you can see the cutoffs here in the bottom box, have the equivalent rate of an IBI versus a full term of the same chronological age. So the younger children at likely increased incident rate of increased risk of IBI versus the older children as they get older and older, they sort of act the same as they would a full term colleague of the same chronologic age. Second study done in the journal Pediatrics a couple years ago, showing that preterm infants actually had a lower rate of UTI than term infants, and this was in children less than 2 months of age. They showed that preterm and term infants actually did not have statistically significant different rates of bacteremia and bacterial meningitis, suggesting that we should treat these children the same way, sort of based on their chronologic age. Recent study just published over the last month. Brett's an author on this as well, looking at whether we could use the AAP recommendations and the updated PCARM prediction rule in preterm infants. Great table here in table 2 below. You could see going based on the AAP recommended risk stratification, procalcitonin and CRP, procal and ANC, CRP, ANC, and temperature. misclassified 0 children as low risk when they were febrile and preterm. The PECARM prediction rule, you could see here, it missed 1 child who had a UTI. So there were no missed IBIs, bacteremia, bacterial meningitis, in these children, premature babies less than 60 days of age with a fever. So this would suggest to me that I'd have a lower threshold in terms of what I would do, lower threshold for testing in the preterm infants. I would do probably more blood testing in these premature infants than I would their full-term colleagues. And yes, the evidence would suggest that we can use the same risk assessment tools that we use for the febrile infants for those hypothermic infants. Those are all my cases. Again, a QR code. I encourage everyone to check out my blog, Hypocristes. We try to publish on a weekly basis on all different clinical topics. We have some stuff about AI. We have authors from across the country and across the world who contribute, and so I'd encourage you to check it out. You could put your email into the pop-up that comes up, or if you scroll down, there's an area to subscribe. You'll get each of the posts as we publish into your email. I'll share my email here if there's any questions about the lecture, or if you'd like to contribute to the blog, I'd encourage you to email me. We'd love to have you contribute. Thank you very much.
Thank you so much, Joshua. That's amazing. I'm gonna get you to go back a slide so people can capture the QR code for your blog. Any questions for Joshua? I can start us off because we have an interesting group of, like you said, people from around the world, a lot of Americans and a lot of Canadians. How much of febrile infant management do you think is related to medical legal versus our evidence base or somewhere in between?
Yeah, it's something I think about a lot, and I think if you ask clinicians, and be interesting to hear from the group we have here, clinicians of different levels and different years of experience, I think their answers will be different. I tend to think about, I could probably count the amount of times I've seen true bacterial meningitis uh, in uh, in infants, probably on a couple hands. That is compared to, I'll call him out. My dad's a pediatric emergency doc. When he was training, it was a regular occurrence. He talks about doing spinal taps in the ED up to 3 months of age. You would see the purulent fluid coming out as soon as you got the needle into the spinal canal. So I think that frames some of the approaches as well, in terms of just how the trainees and the less experienced clinicians or sort of the younger clinicians approach these things, because I see the data and say, okay, the risk of bacteremia and bacterial meningitis based on these studies is quite low. And then I talk to my colleagues who've been, practicing for decades and decades, and it's a hard concept sometimes to stomach. Okay, we're not going to tap these children who are 3 weeks of age. So that I would say is one of the things that I think about. But yeah, I'd be interested to hear from the group.
We have one of the authors of the couple studies that you cited. Brett, go ahead.
Hey April, hey Josh, how you doing?
Good.
Apologies, I'm driving between childcare functions. So I love your talk, and in particular what you've done here is focused on all of the gray areas. And we've spoken recently, and I do a lot of talks about the what I'll call the normal cases, like the well-appearing febrile infant that meets all the basic criteria. And I like that about your talk. You're starting to address all of these other areas that are a little more called the third month of life. I think you mentioned premature infants, viral illness, like all these other, like they don't quite fit the criteria in any country, like wherever the guidelines are. They're like gray cases. So we've got a cool meta-analysis coming out in like about a week that'll inform some of that third month of life, what to do. But my only one question for you is, you started your talk with the reference to CHOP, which is like field leading in algorithms. Really, like people turn to it as a global reference. They're outstanding. The number of them, they're rigorous, and people know them as like online resources. My question is, will you guys update it soon for the first month of life? That's my question.
It's a great question. I will say I'm not directly involved with that specific pathway. I don't have firsthand information in terms of whether it will change. In the conversation, Brett, that we had, me, you, and Nate, I know that there was a discussion of the AP clinical practice guidelines is going to be looked at again over the next year. I would imagine if it is changed in that, that would likely, I would guess, would probably inform a potential change in the CHOP febrile infant pathways, but that would be just a guess. But I don't have direct knowledge in terms of that, unfortunately. I don't know if there's any of my CHOP colleagues, if they're on that can speak to that as well.
There's an identical question in the chat. Clearly, people feel would like that to be updated. Yeah, maybe you
I
can
will
chat
I'll
with the
pass that
top
along. I know there's been some discussion in our faculty meetings about it, and certainly people have looked at the papers.
Yeah.
Hopefully we may have some news coming out at some point, but I don't have anything for you quite yet.
Mike?
It raises an interesting educational dilemma since the vast majority of experience from LPs was ruling out meningitis back in the day. I mean, how are we going to teach people to do an LP anymore? It's the same problem we face with non-invasive ventilatory management, which is, don't get me wrong, is incredible, but we lose all of that. And I see the post about sim centers. I used to run one. There is a limitation as to how much you can get out of a sim center. I think especially when it comes to LPs, I'm not sure the LP models are that great. Maybe they've changed.
No, I'm with you 100%, Mike. I think yeah, the there's nothing the best way to learn it is to do it on an actual patient. I agree. I think that as good as the models have become, it's still a little bit different. And yeah, I think it's tough. I mean, we have uh PEDS residents who go through their 3 years of residency and then go into PEM fellowship, and they haven't done that many LPs. So then you think about it, okay, are they going to go to fellowship and take all of the LPs, or they can then eventually be in the teaching role and have to teach residents LPs when they haven't even done a ton of them. So yeah, fewer and fewer, which I think, as the studies have shown, our first attempt success has gone down and down just because people aren't doing them as regularly. I think it's a tough thing.
Stuart's asking if something's being missed in these decision-making rules by essentially only using labs as opposed to more formally adding clinical features to the decision making.
Yeah, I think my perspective on that, and again, those in the group who have done direct research on this, I would defer to them. But I think the key to this is that it is a well-appearing infant, however you want to define that. If your clinical gestalt is that this child is not well-appearing, of course, no one is going to fault you for doing a more complete workup on these children. So I think for well-appearing infant that you would not clinically be worried about, it gives us a more of a strategy to risk assess these children, would be my perspective on that.
Brett, did you have thoughts?
I mean, I always have some thoughts, but I thought Josh did a great job answering, to be honest. Clinical appearance is the most important predictor of invasive bacterial infection. So if when in doubt about what well appearing is, err on the side of caution. That's what I would say.
Joe asks, are you anticipating a big chance with the vaccine schedule in the US changing? Oh,
Yeah,
big change. Big
yeah.
change. Is it actually officially changing? Oh my God.
I can't answer that directly. Don't know 100% what their directly recommendation. I mean, I hope not. Uh, I think that the recommendations for the vaccines that prevent some of the more serious infections that we see are still part of the recommendations. So I hope that that won't change. But I think, of course, the big thing is vaccine refusal, and something that I'm sure this group has talked about, and either in this setting or in their own settings. I think even more of a role that we have as emergency clinicians that maybe didn't go into primary care so that we wouldn't have to talk about some of these things to families. I think more and more of a role. I mean, we see a ton of patients who the family comes in and they have refused vaccines, and then they come in and they're worried about meningitis. And we explain to them, well, one way to reduce your risk of meningitis is to get the vaccines. And so Sometimes it's a lack of education. Sometimes someone just hasn't sat down with them and discussed it with them. And we see plenty of times that we discuss these with our patients in the emergency room, and okay, now they're agreeable, whether that's because they trust us for whatever reason versus other people that they're hearing from. But I think even more and more of a role that we have to play to make sure that the vaccine refusals and vaccine hesitancy is not going to impact things going forward in terms of bacterial infections we see in these children.
Yeah, there's just some echoes in the chat about there has been an increase in vaccine refusal in the US, and that varies from state to state. I mean, I think we see that too in Canada. And just somebody else is saying AP has published their own vaccine schedule without change. Courts have blocked the HHS CDC from changing, but as Dr. Falk has said, there is a lot more vaccine refusal and hesitancy based on the bully pulpit of the current leadership. Do we see a day where it's even more on the other end, like conservative to the point of where missed IBI just stops justifying the harms of over-investigation and hospitalization?
It's a tough question. It's yeah, I mean, it's what's your risk tolerance? I think yeah, again, thinking about, and I know we keep bringing it up, but it was a great insight in the interview I did with Nate and Brett in terms of, okay, these first few weeks of life, you're still doing the blood testing, you're sending a blood culture, so within the first 24 hours and probably sooner, now with the amount of, the testing modalities we have, you're going to identify bacteremia and you could get this child, spinal tap, antibiotics at that point. So yeah, I think it's the question of, do we need to sort of how long is too long to wait before we identify these cases? And I think there's a case if you're going to be in the hospital in a setting that you can be well monitored while you have a blood culture pending, 6, 8 hours, maybe is appropriate, some would say, in terms of between the testing and between when you get the result. Others I'm sure would have different threshold in terms of, you want to know right away, you want to do the testing right away, so you could see the CSF count, and then you could treat for bacterial meningitis right off the bat based on the CSF count if there's pleocytosis. So I think it's about what risk you're willing to tolerate.
Awesome. Does anybody else have any last minute questions? Otherwise, thank you so much, Joshua, and hopefully you get a few more hits on your blog. Curious as to why you picked a blog versus the podcast, or do you do a bit of both?
I dabble in both, but we'll see. AI may take over the blog at some point anyways and put me out of business. But no, but thank you. And yeah, certainly I love if people, look at the blog, but I think also if people want to write for it, speaking of AI, we've used some AI tools to sort of easily convert lectures you've already given, PowerPoints that you already have, into blog posts, minimal lift, and that way you could sort of teach clinicians from all over the world at every stage of training. So thank you.